The goals of DBT-based treatment. So when I am working with a client who they're struggling with emotional regulation, distress tolerance, interpersonal effectiveness, living in the present moment, there is a mindfulness component. If someone was really struggling with being mindful, that wouldn't in and of itself have me thinking, do we want to inject some DBT? But definitely the emotional regulation part and the distress tolerance. So when we're working with someone on anxiety and we have to bring on discomfort to practice moving through the discomfort. And we always tell someone like, that's not dangerous to experience anxiety. We're going to teach your brain it's maybe uncomfortable, but that doesn't mean you can't handle it. What does become dangerous if when someone feels really uncomfortable emotions to them and they have an exquisite sensitivity to that discomfort, if they engage in cutting, if they use drugs, if they act out in some dangerous, impulsive way, we're not going to want to bring on emotional discomfort if we don't think, if there are signs the person might engage in coping behaviors that are going to be dangerous. So that's not the average person. And sometimes we could tell in an intake if somebody's had a history of engaging in self-harm, a history of like suicide attempts. These are signs, substance abuse, what are the triggers for them? And then how do they engage? How do they move through these challenging moments? Sometimes we're not going to know. For example, I was once working or maybe supervising a case, all blends together, where it was a teenager, maybe a freshman in high school, always straight A student, he was a freshman in college. And then come his finals period where he was like, I don't know if I'm going to do well, I'm going to fail. And then he started having panic attacks. And then he started saying he was going to drive his car into a tree and making these big statements to his parents and different ways of kind of escaping from feeling like he was failing. So we were doing exposures for the panic attack, but we didn't know until it surfaced for the first time in working with him, the clinical history, when feeling emotionally dysregulated and distressed, this would be a behavior that he went to. And I think he surprised himself as well. So sometimes we're going to know from the start, this might be a good case to infuse some DBT. Sometimes we might find as we go. Sometimes by the time we notice this, it might be time to refer to a higher level of care. So just because we can infuse some DBT practice in distress tolerance, emotional regulation, doesn't mean we should. Because if somebody is engaging in anything beyond mild self-harm, they deserve 24-hour support. They deserve the full DBT model, which does allow for 24-hour support in that somebody could call, and as long as they're practicing engaging in a healthy coping skill, they have the availability. So like the full DBT model normally is housed in an IOP or partial program because when someone is feeling dysregulated, those are the time to have all hands on deck and try to help them get through those moments. So I would say like we do more of the DBT light in that we're offering the skills, we're offering the support in terms of both how do we validate what you as a person are valid, your concerns are valid and change. You also deserve to live a life that's effective on your own terms. So we're helping them with both. So maybe I'll play this video in terms of like, this is Marsha Linehan and the development of DBT skills.
I started working with highly suicidal people. As it turned out, the people met criteria for borderline personality disorder, but A, I had never heard of borderline personality disorder, and B, I didn't know what it was. Even if you told me the name, I wouldn't have known. So that was the beginning of the whole thing. I had no idea what I was doing, except that I was studying suicide. What happened was standard behavior therapy of the 1970s and early 1980 blew up. And the main reason it did is because what it requires for it to work is for a person to come in and you be able to say, okay, here's the problem and here's what we'll do to change it. And for the person to say, okay, I'll try that. But the people I was dealing with immediately said, you're saying I'm the problem. And so they were so sensitive to any invalidation or statement that they were the problem that the treatment blew up. And they would either get angry at me, hide behind a chair, storm out, quit therapy, yell and scream, cry, or say they're going to kill themselves. So it didn't take me too long to figure out this was not going to work out. So I thought, okay, we're going to switch to a more acceptance-based treatment. So I'm going to validate and be very accepting. So I tried that. That blew up also, because then the patient said, you mean you're not going to help me? You're just going to listen to me? Most of the patients I treat have already been through a whole lot of therapy where you talk, get listened to, and understood. The problem is talking, being listened to, and being understood doesn't necessarily make anything change. So then they got really upset with me because I wasn't helping them change. So that's when I realized that I had to pull together a major emphasis on change with a technology of acceptance. So I had a technology of change, now I need a technology of acceptance. The technology of acceptance primarily was validation. So it's behavior therapy with a huge amount of validation. So problem solving, validation are the core components of the treatment.
And it could feel intimidating, like exploring DBT, but not super hardcore, everything you do being as a DBT provider. And so I'm glad that we could kind of find different ways to use it for our clients in ways that make sense. So dialectics, which Linehan just discussed, I heard someone introduce her as Linehan. Does anyone Linehan? It looks like Linehan, but is it Linehan? Does anyone have the right way to say her name? Bonus points.
Pretty sure it's Linehan. I had a colleague work with her directly.
Linehan? Because I thought it was, and then I feel like someone corrected someone, and that makes much more sense that it's Linehan. Okay, I'll say Linehan because that's actually easier to say. It's hard to say Linehan. So Linehan discussing kind of that dialectic, that sweet spot between acceptance and change. And I think it's something we do try to do with all clients, especially from a CBT model, like we're saying, change is possible, but also always from a place not of judgment of as your starting point, you are a valid human being, but to make that so explicit, especially for when individuals are engaging in these ineffective coping behaviors that we want to start using DBT. What's interesting is really studies showing that for those who are so quick to feel rejected, so maybe for the average person, it wouldn't even feel like much of an insult, but for someone who's struggling with borderline personality, it's hypersensitivity to anything that feels like rejection. Their brain is just picking up on. So really kind of going heavy duty on the acceptance side and making it explicit, I think, is something that we want to be doing for all of our clients. And so the skills within DBT on the acceptance side, mindfulness, distress tolerance, that sometimes we can't change, that the distress is happening, but how do we, by opening up to it versus fighting against it, we can move from suffering to just pain. If we can change things, that's great. But when we can't, how do we learn to tolerate that? But then on the change side, there are these emotional regulation skills, things that maybe in traditional CBT, especially for anxiety disorders, we might say like, isn't that a compulsion? So feeling dysregulated, holding an ice cube to change your emotional temperature, or maybe knowing what songs might lead you to think about a relationship breakup, lead you to cutting and removing those songs from your playlist. So it might sound like avoidance, but sometimes there's a time that it does make sense to avoid. And so in terms of emotional regulation, that could be different toolboxes of when a moment is hard. We don't always have to go full throttle through the exposure, but we can choose to change the scent and smell something nice, or take a warm bath. Hannah, do you want to jump in?
Sure, yeah. This literally came up with one of my kiddos this week, where it's a lot of what her parents get frustrated with is she feels a lot of their, like, if they think anything that she cares about is trivial, it's immediate, like, they're dismissing me, it's no one's validating me. So having dad in session and trying to like discuss validation for like, okay, it might seem trivial to you and mom, where we're considering the rest of the family and all the other stuff on our clock, but like, it's not trivial to her, the client. And like discussing though what client can and can't control, because that aspect of like, no one's gonna like me at school, no one's gonna, like, what can I do to change that? But how much is in our control and how much is not? So I, like, as you're talking about this, Dr. Kissen, I'm immediately thinking of her and like, okay, how much can we like keep applying this? And also like how much they understand versus they don't. I noticed like a lot of the what we can and can't control for younger kiddos, it's like, no, I can change their mind. It's like, ooh, okay, got it. How do we come at this with a different perspective?
And one of my favorite parenting books, which I'm going to not now remember the name, but it has a DBT framework for parents to understand their strong-willed child. So it's not parenting your strong-willed child, and we probably have in our recommended books, but sort of helping the parents understand, like, when they're having that meltdown, like they're not just trying to be difficult or trying to be dramatic, but that was a soul-crushing blow to their brain for you to tell them that's a waste of time to be doing something. That little thing for their brain was that challenging. So I think it allows for that education for parents on what's happening, can help them then, the parents, to start acting differently. I'm not just giving in to them when they're being a brat, but like their brain is saying they were just rejected. I could respond differently. So it kind of gives permission for the parents. They're not bad parents. They're just trying to understand the child that they do have. So I really love giving parents that framework, because it's not intuitive when you just have somebody have a total meltdown when you made a little comment to them. And if I'll get you guys the book if I can't remember which it is. We have so many great books. And so another change on the change side of DBT, interpersonal effectiveness. And we have some really great required trainings. Dr. Franklin doing a sample exercise. I was the sample client of within the interpersonal effectiveness skills. And that is something that we can change. We can't always change what the other person's going to do, but by changing our reactions is going to bring out then a different behavior in the other person as well. And so it's really helpful no matter what, when a client is struggling with interpersonal effectiveness. So the comprehensive DBT model is going to involve every client has to do a DBT skills group. We do have a DBT for anxiety group here that Eleanor is running, and it's wonderful, but it's not a traditional DBT skills group where it's following the exact protocol, but it's a really nice way to practice these skills. So we do have that going on. So anyone in a traditional comprehensive DBT model needs to be part of a DBT skills group. They also need individual therapy. There's phone coaching available, like I said, 24/7. And there are different ways that the phone coaching, I guess I wonder at this point if it would be text coaching. I would hope so, but I don't know. But when somebody responds, they're trained that they have to at least say, like, I've practiced this skill. What other ways can I get through this moment? Because what was determined within DBT is that people want help, but the way that they engage in it is through these ineffective behaviors like cutting or very big displays. And so instead of reinforcing, okay, you're not hearing me now, I'll have a bigger display. You're not hearing me, bigger display. And then the mental health system and everyone around you starts attending when it's, oh, wow, I guess you're really in pain because you just had a really big cutting experience. Like, how do we reinforce people when they're actually engaging in healthy coping? And it's kind of the, I was going to say the squeaky wheel gets, but I don't even know that expression. So, but the point is we don't want to just reinforce the squeaky wheel, but it's harder to catch those moments of effectiveness. But that also involves having your being available in a way that that's not really part of what we do. So in treating really specialized in anxiety disorders, part of it was a lifestyle choice also. In if we want to, I want to be on call all night and over the weekends. So knowing what we treat and when it's time to refer to an partial hospitalization program or an intensive outpatient, we're so lucky that we have so many great community partners to ratchet up the levels of care. And DBT, like I said, can be used for eating disorders, substance abuse, borderline personality disorder, OCD, general stress management. So next slide. Oh, let's watch this. I haven't done DBT for 2 years in Learning Labs, so this is fun. Okay.
The good news is that's probably good for everybody. The only reason I know that is everybody I know uses them that's ever learned them. I use them all the time. Just about everybody can use skills to be more skillful. I mean, the only people who don't need DBT skills probably are people who are very regulated. So skills are really good for depression, post-traumatic stress disorder, drug use, anxiety disorder, etc. So skills are really about how to be effective. I mean, essentially, beginning to end, they have to do with how to engage your life in an effective way, how to act effectively. The average person can do the skills. They're not that difficult. The only real thing that happens is that you often have people who get furious at you for telling them the skill because it sounds like you're invalidating them. The job of the therapist is to figure out a way to make you see that your life's going to be a lot better if you buy in than if you don't. And you'd be amazed at how many people, if they try it long enough, they'll then start saying, wow, you were so right, I feel a lot happier now, or I feel better, or this, that, or the other. Generally, if you can get people to practice for a while, and you don't give them too much of a hard time, what most people will find out is that over time, they're happier using the skills than not using the skills.
Very nice. I like that. Thanks, Lisa. Okay, so mindfulness. So on the acceptance side, it's a good reminder where mindfulness hangs out, because a lot of the time we think of mindfulness, or maybe we don't, but people can think of mindfulness and relaxation. Relaxation is change. Like, I'm stressed and I want to calm down, take my emotional temperature down. Mindfulness is about opening up to what is, and I'd say more in like popular health media, they could kind of bucket them together, but helping a client or working with them to practice that mindfulness muscle is about how do we choose the anchor, like where do we want to attend, what is valued in this moment, and then whatever comes along in the process, noting it, like describing it, like, oh, I'm having the thought, it's Halloween and I didn't buy candy yet. Okay, I'm having that thought. And then I'm going to now gently return back to the present moment. So I'm not like, I'm not fighting against that thought. I'm not trying to change that thought. I'm just directing my attention to what's important, what matters in this moment to me. And so mindfulness skill building is one of the components within DBT. Next slide. So just highlights that we have different DBT resources in Paycom. If ever we're finding one is either redundant or you guys aren't finding as helpful, we're also removing. And if we find a new resource that's great, putting it in. So this slide might not be up to date versus where we're at right now. Next. Okay, so starting with emotional regulation and distress tolerance. So everyone, I think part of temperament has a different natural level of emotional regulation. I'm feeling really frustrated. Okay, I'm going to calm myself down. How effectively are they able to navigate within when they're feeling frustrated or upset? Okay, I can't do anything about it. And everyone has a different level just naturally of distress tolerance, from babies that are, if they're a little bit hungry, screaming their heads off, or depending on the material of clothing, more sensitive. So we are kind of hardwired somewhat in terms of how well we're start off in terms of emotional regulation and how much we're bothered when things aren't the way we want them to be. But the good news is we're able to build upon that and rewire our brain at any point to get more effective at both of those skills and qualities. Next slide. So kind of highlighted this a little bit in terms of what you guys are going to see, what we see. And sometimes we see more than we should see. And we might get a referral that it sounds like the right fit for us, and we don't learn until months later that there's something more that they might need. So in terms of what we consider ineffective coping behaviors, our standard worrying, engaging in compulsion, avoidance is a way of emotional coping, or handling I don't like how I'm feeling, so I'm going to, if I could just worry and think my way through it, or engage in a compulsion, ruminate what happened in the past, just avoid doing that, I will feel better. Those are internal ways that they work in the short term, but they don't actually solve anything. But we humans do engage in them for emotional coping. And then they're externalizing, like I feel really out of control and I gotta grab a bottle of vodka to try to calm myself down, or it was a hard day and I don't want to think about my career and how out of track it is, so I'm gonna binge eat. I don't know how to handle what my child was saying to me, so I'm gonna lose control and yell. They all start with having a hard feeling, something that we don't want to have, and then doing a natural thing of trying to regulate that emotion, but in these ways with different levels of harm that it could cause, ineffective in the long run, but fully rational. They all work, and that's why we humans do them. And it's just a matter of how they start impacting one's life and takes away from valued living the more, whether it's internalizing or externalizing. When life feels hard, we engage in these things. We might find our world getting smaller and smaller and further away from what really matters to each of us. And so, as we've spoken earlier, if some of the ineffective emotional coping behaviors are becoming more dangerous and someone deserves more support, that's when we're starting to look at external referrals. And I think the point of this slide is, there's a few different points, but just like the language of, yes, you're binge eating, that's because it works. It might not be effective long term, but it doesn't make you lazy or any less than as a human. It just means that when you engage in this behavior, you get a relief from something that is really uncomfortable. So I think no matter what, always validating that, you know, people are doing something that makes sense in the short term, and just bigger picture, it's getting in the way of life for them. And so just kind of the whole shame thing, I think we're all really good at that. I think mental health in general is not. So I think I believe that we as a practice are better than most at really watching out for any shamey language and catching ourselves when we are engaging it. And that it's going to happen, but just understanding when maybe there's a different way to talk about something. Does anyone have any thoughts about, in terms of either when to refer out or even how we talk about ineffective coping behaviors with clients? Anything comes to mind for anyone? Danielle?
Yeah, Laura and I are both working with this client right now, actually. And he has some pretty severe OCD, amongst many other things, but that's mostly what he's coming to LOA for. And there's also some, like, I don't even know how to say it because I struggle to say it, persecutory delusions. Like he's having some psychosis a little bit mixed with it. And so trying to figure out whether or not he's a fit here and not at this point. That's kind of where we're at.
Yeah. It's so complicated. So many different thoughts coming up for me with that. So sometimes, well, can you give an example of the kind of persecutory, and I can't say it either, behavior or thought, and how it's impacting his life? So say, for example, he's running down the street, like, they're trying to kill me, and then he's stabbing people, like he's going to end up in jail or killed. And so we really want to expedite getting help because that's going to be really dangerous. Or they're trying to take my money, so I'm going to spend it all today. Like, depending on how much harm it's causing in his life. Also, depending on, say somebody is currently able to work even with this, and the structure of that, it would be more harmful to try to get them to do a different kind of program, or they would refuse to do a different kind of program. If we're doing more good than not, because at the end of the day, they're not going to actually, we could say, you should go to this program that specializes in, although there aren't really great programs that specialize in it, often it can be more inpatient anyway. But so we just kind of want to always figure out what overall is, even if it's not the perfect solution, is the most compassionate, the most kind, effective thing that we can do for them. Because the thing is, there's never a perfect provider out there. And so it's never straight, well, that's not what we specialize in, so therefore we need to terminate care. Because then it's the question of like, well, where else are they going to go realistically in our community to be considered as well? So given that big data dump, any clarifying information or questions?
It's a very complex case. Laura, if you have anything to add and want to jump in at all, but he's seeing somebody else outside of LOA for, I guess it was just talk therapy. I don't really even, he just finished at Rogers OCD program in September. Before that, he was in Compass's program for depression with some SI. There was an attempt. So there's kind of a lot going on. And then Laura and I both talked to his other therapist at wherever they are. I think it's Live Oak. And they were like, yeah, he's having persecutory delusions. Like he thinks like his like he says that it's unsafe to go home, but he's not talking about feeling unsafe with his parents. He's saying that the actual house is out to get him. It is unsafe. And he has made comments before about being the Antichrist. So
I would say
that's
this would
kind
be
of in
a
this-
great,
yeah.
I think a diagnostic clarification treatment planning would be great. Have you guys done one yet for this case?
We have not. Has a psychiatrist and has had neuropsychs before recently as well. So, I mean, currently he has an ASD diagnosis, ADHD, anxiety, depression,
So the point
OCD.
of the point of when I think of like a good diagnostic clarification case, it's not exactly neuropsych testing, and it's more like there's so many moving parts. Taking a step back, and we call it like diagnostic and treatment planning, given all of this different data, what next steps do we recommend? He's being bounced around anyway between Linden Oaks and Compass and Rogers, and so I see it as sort of like the blind people and the elephant. Like there's all these different parts, and sometimes this is someone coming in for a session or two and helping to organize the information. Like I would want that for this kind of case. And because if there is it's never gonna be a perfect solution, but if there's a better solution, we always want to move in that direction. It's hard to know, and an additional lens might be helpful.
Yeah, to jump in, I was just going to add that I think we're very much in the information gathering stage. We haven't really seen him for very long, so definitely something to think about as we go forward, for sure. Appreciate that.
Yeah, and a lot of it's also understanding the different treatment providers that are out there too. Thinking about what Linden Oaks is pretty good with ACT, and kind of understanding his journey. It's just so many parts that you guys are moving through that you shouldn't have to figure it out alone either. I mean, it's not alone because you're working with your supervisor, but it sounds very complicated. I think we do well with complicated people because we can work as a team, and then we could add in a little testing. And maybe I don't know, I would just say from the psychiatrist, I would hope the delusions were going down. I don't know how actively the psychiatrist is working with him, but it feels like there might be another medication because he's still suffering a lot. So complex. David?
We went to the psychiatrist on Tuesday, actually. So we'll see. I'm going to see him tomorrow. So we'll see what the psychiatrist said.
And also, it's sort of hard, like the coordinating of care is a really hard part in the mental health industry. So like if this was my child, if this was me, I would rather have like a prescriber, someone who doing the assessment part that's in one place as well. So I'm not saying all these parts have to move in, but it really is hard to coordinate with external providers to try to be on the same page. So David?
Yeah, in a similar vein, I kind of wanted to ask, I'm sure the answer is it depends and it can be complicated, but when cases are more complex like this, generally speaking, are we requesting at least a diagnostic clarification session before considering referring out for a higher level of care? Or
It's a great question. I would say unless somebody is in like immediate harm to self or others, we're pretty much calling 911. We're pretty much or it's so clear cut. But I've yet to find it being that clear cut. Like, say someone, they're only concerned with substance abuse. I don't think they would have gotten that far with us anyway. So if it's so obviously substance abuse, that's also normally their starting point. What I found is even deciding where to refer them to, and are they going to actually do it, and given their job, if they were to do that, maybe they're going to lose their job. Are we causing more harm than good? There's normally some mixed questions that it's not as easy as it sounds, I guess. Ideally, they should go to Rogers Residential because their OCD is off the chart, but they're supporting their family. Like, if only it were that easy, they probably would do that. And so I would say most of the time, if we're working with someone and then it means referring out, it'll help to be a little more precise and have a little bit better of a plan to support them with the transition. Thank you, Jessica. But I like this topic in relation to DBT, because when we start talking about DBT and when we're using it, like, this might be a client that we're learning more and more they do need additional support beyond our DBT light on top of CBT and ERP. And just knowing with compassion how to orchestrate handoffs with other providers. Like, a lot of people get lost in the shuffle, and we could recommend something, but then they don't go, and then they're just kind of lost again within the mental health care system. So it's just, yes, David, it is complicated, but I would say most of the time it really can't hurt. We're never looking to waste anyone's time. We want to save them time by slowing it down enough to see the full landscape. I hope I didn't fully hedge the question. Yeah. Dr. Heather, coming in from do you have anything coming in from different environment with a wealth of knowledge? Is anything to share on DBT, on anything?
I know I'm in the onboarding group that's switching books, but I actually own the book that you guys had looked at and read. And one of my favorite things to use from that book, in a DBT light kind of fashion, is actually the rights page. It's towards the end. There's a page that talks about the undeniable human rights. I really use that as a self-introspective reflection for people who aren't very good at setting boundaries or saying no. Like, that is good across, like, even not high acuity. Like, it's just one of my favorite, like, skills exercises to use. I don't have the book in front of me because I didn't know what we were doing in Learning Lab today, but to tell you the page number. But if you look, it's like a checklist of, like, I have a right to say no. It's all very, like, neutrally worded. I don't know if anybody is familiar with the page.
Is it within?
It's in the green DBT workbook. Mm-hmm.
In interpersonal a skill within interpersonal effectiveness.
Yeah, I can take a look and maybe send an email on the page. I can grab a copy of it here and let you know.
Hey.
I just don't have it in front of me to know, but it's one of my favorite, like,
Dr.
just
Heather,
random skills to use in general with people.
right.